So certainly within the medical sector, but we also want to think about mental health, so behavioral and developmental issues, as well as the educational sector, and thinking about the social and financial issues that our families face. This is all under the premise of the medical home, which in the words of Rich Antonelli is necessary but not sufficient, and that's where care coordination comes into play. Next slide, please. So when we dig a little bit deeper into care coordination in practice, and you're going to hear more about this from my colleagues, we want to think about case management, which we often hear about in the insurance sector, versus care coordination. The work of the policy statement very much is operationalized under the premise of community-based care coordination, working within the practice and again across sectors. We also, right now in the era of healthcare reform, it's important to talk a little bit about whether care coordination in its purest sense is getting paid for. Recently, about a year ago, Medicare did identify some codes that I have there, and we're happy to share some links to articles and briefs that talk about those codes and that are now being recognized by some payers. But one of the most important things is whether or not the act of care coordination itself is reimbursed or linked to a code, is whether that care coordination itself, in fact, may foster quality improvement, that for some of us may actually enable us to get paid for quality incentives that ensue from care coordination and the efficiency in practice. So sometimes it's payment, but it's not always part and parcel, because it's the downstream beneficial effects to both the family and the positive and favorable outcomes that ensue on our practice. It's also important to think about care coordination in terms of workforce development. I'm going to talk a little bit about that at the end of my section about the curriculum and the ways that we can not only train physicians that are currently practicing, but thinking about residents, social workers, nurses, our parent leaders, and really social workers. So across all disciplines, we need to develop the workforce with an eye to care coordination. I'd be remiss if I didn't talk about health IT. For those of us that trained years ago, we have had to really adapt to this new wave of electronic health records, but health IT is a wonderful thing, in my opinion, as far as care coordination goes. It allows us to now do care plans in our EHR and not in Word documents or handwritten. It allows those care plans at times to be shared or maybe on a website that can be accessed via a patient portal. Patient portals foster care coordination. They allow families to request services or referrals. We also can use registries, personal health records. So again, health IT is certainly a tool that we can use to accomplish the tenets of care coordination. Next slide, please. We also want to think about care coordination and the role of a team. So make no mistake that as a Philadelphia native, I'm not a Steelers fan, but that little logo there is for my dream team. I have to acknowledge that in Pennsylvania we're a little dichotomous with football. But, however, aside from that, I think that teams, whether or not you're a football fan, are essential in medical home. So we know that even outside of the United States, even in the United Kingdom and in Canada, there's this acknowledgement that teamwork is essential. We think about patient care delivery, even when we're doing codes in the hospital and clinical teams. Teams are paramount. They foster practice improvement. There's quality improvement teams. And so when we think about developing work in medical home improvement, we think about quality and safety and making sure that not one nurse or one person is going to get burned out. But we have to recognize that there's not just any one person that can meet the needs of the patient and their family. Next slide, please. We have to recognize, and that's where care coordination comes into play, is that we have this reciprocal and honest communication. There's my Eagles. And we also have appreciative inquiry and this concept of relational care coordination. Relational care coordination, Dr. Carl Cooley was someone who introduced this concept to me. And this is something that comes out of the business sector, but there's lessons to be learned here. And it's this idea of the quality of our communication and relationships. And we can translate that into our work in the medical sector and with our community partners and with families. And so we look at this idea of management, and we're managing people, and we're looking at working to the top of our license, performing tasks and integrating across the community, seeing that there's folks in the community that are also coordinating care. Next slide, please. So as we think about operationalizing care coordination, again, this idea of the team, and you're going to hear from a team today, a team of folks, and it's pretty telling that when we talked about even planning this webinar, the team very organically said it can't just be one of us. All of us need to be on this call because in our practice, and you'll hear from Pediatrics South, which is a stellar practice in the Commonwealth of Pennsylvania, that they operationalize the work of care coordination across not just one person. And I think it's very important to note that on the slide where we look at the various folks that you can read here that represent the team, families are number one. We have to remember that families are equal, if not more important partners, and they have to be at the helm of this team. In some practices, we have parent partners. We have to think about the patients, certainly all the clinical folks, but again, remember administrators are part of your team, and also office staff. Your front staff are the folks that are often the first folks interfacing and meeting our families. And never forget the community partners and our educators. Next slide, please. So one of the things that, again, I just want to underscore that family members are key members of the team, and we felt like that really warranted its own slide. We have to keep that at the forefront, and we're going to hear from one of our family members today. Next slide, please. And we think about the tools for fostering this family-centered care and teamwork. So certainly care plans are important. I'll talk a little bit more about that. Thinking about staff meetings where in a medical model we can come together and talk about what we're going to be doing. The concept of patient huddles where a few minutes before we launch clinical care we run through the patients, talk about issues, hear from everyone on that team from the front staff to the nursing, physician, care coordinator. Looking at things like working with our families via resource nights where we bring in community partners, maybe looking at contracts or advertisements, working with our family members to create newsletters, whether they're posted on bulletin boards or electronically disseminated. Also thinking about family and faculty in some scenarios where there's teaching that goes on, where we recognize our family can be teachers and are part of the faculty, looking at family advisory councils that can advise community boards or hospitals or practices, and also looking at community partners that would come in and work with us and have liaisons that we work with directly. Next slide, please. These are all tools to foster this family-centered care and teamwork. And so when we think about care planning, which is important, and I mentioned earlier, we want to think about identifying who would need a care plan, talk about the value of that care plan, and making sure that part of that, and you'll hear from our practice that does this, that they assess their youth and family, setting goals with the family, and linking to partners. Next slide, please. And those partners include both community partners as well as specialists and anyone involved in the care of the patient and their family. We want to establish that plan and include goals in the care planning and really have, obviously, the parent and the family and the patient inform those goals. Make sure that plan of care is accessible, that it's retrievable. Is it electronic? Is it going to be accessed from a website remotely? Who has the password? We have to make sure that when we create a care plan or we do care planning that we track it, that there's oversight. It needs to be a living, breathing, either document or electronic entity, because we have to continue to make sure it's the repository and locus of information from all of the partners involved in the child's care plan. Next slide, please. And we want to make sure that that plan of care we think about as a life course perspective from, transition through adult-centered care and into the adult sector. I just included the slide that you'll have as a resource, just some ideas if you're developing care plans or thinking about in your EHR where you can create a separate field that's populated from things that we put in the electronic health record. These are some things that you may want to consider putting in to that care plan. Certainly things like past medical history and medications and home nursing are important, equipment and therapies, but I want to just highlight that it's important to recognize that care plans should include needs and strengths. They should include things that also the goals, alternative therapies, and as well as when appropriate, looking at transition to adult-oriented systems as well as, if relevant, palliative care. Next slide, please. These are things that can be created electronically through our electronic health record and, again, represent the advent of health IT. Again, to underscore that families need to be involved. If relevant and possible, they can get a copy of that care plan at the end of the visit. In some cases, it would be great to make that care plan accessible via the patient portal. So now a family can access it, whether they're in the school or at a specialty office or somewhere where many of us know our electronic health records don't talk to each other. So that patient portal can be a commonality. We want to make sure that the parent can actually review it before you print it and it's discussed. And at times even have maybe the family sign it so you know they're reviewing it. And in one of our studies in our own medical home program, we found that not all parents got a copy of that care plan. Next slide, please. So I just want to highlight that that is something that needs to happen. Letters of medical necessity are important to think about as well. And one of the things that I just want to, as I introduce our new team that's coming, you can go to the next slide. The Pennsylvania Medical Home Program is our medical home initiative that is housed at the PH chapter of the American Academy of Pediatrics. Our mission statement is to enhance the life and for children and youth with special health care needs through recognition and support of families as a central caregiver for children, effective community-based care coordination, enhanced communication, and improved primary health care. We are funded, next slide please, through our Title V at the Department of Health, and we work with pediatric practices across Pennsylvania. Next slide please. Across Pennsylvania, the Commonwealth, and we've been a quality improvement initiative since 2001. We employ the EPIC framework in educating physicians and practices in their communities. Next slide. And as I mentioned, we are housed at the PA chapter of the American Academy of Pediatrics. This is a map of Pennsylvania, as you can see, and the dots there represent the pediatric practices that we've worked with over time. And if you look there out to the southwest, you'll see where the Pediatrics South, who's going to speak in just a bit, is located. Next slide, please. We've worked with over 150 practices and have at any time 50 to 60 practices engaged in active quality improvement. One of those is quality improvement activities that we're currently engaged in is the care coordination curriculum. Next slide, please. This is some work we're doing actively with Dr. Rich Antonelli and Hannah Rosenberg, and they are at Boston Children's Hospital. And I'm not going to steal their thunder because they are going to do a webinar. I think it may in fact be the next webinar on their care coordination curriculum. But suffice it to say that we are doing some active quality improvement with a cohort of practices, of which Pediatrics South is one of them, informal data collection, and we're doing learning collaboratives with our entire network who will gain resources, and we're trying to create a community of learners with on-site technical assistance, as well as our learning collaboratives and webinars. Next slide, please. And this slide will be something the next slide you'll hear more about. This is the curricular components that Dr. Antonelli and Hannah will be talking about in future webinars. They have modules of the care coordination curriculum. And with that, next slide, please. I want to turn it back over to Linda, who's going to introduce Pediatrics South.
Thank you, Renee. That was an amazing overview and rapidly delivered and very, very interesting. It is now my pleasure to introduce this dream team, the Pennsylvania team that you see in this slide, and they are the remainder of today's speakers. They are from Pediatrics South in Pittsburgh, Pennsylvania, and they will give you the actual nuts and bolts of how they implement care coordination in their practice. Our first speaker will be Dr. Scott Tyson, General Pediatrician at Pediatrics South. He will then be followed by Brooke Pletcher, who is a certified registered nurse practitioner in the practice with a 20-year career, and she's worked in urban, suburban, and rural settings throughout Pennsylvania. The third speaker is Roxanne Shoup, a certified medical assistant and Pediatrics South Medical Home Care Coordinator. And wrapping up here is someone we want to give a very warm welcome to, Lori Jansma. Lori is the parent partner on Pediatrics South's team, the mother of 4 children. Her children have been cared for in this practice for 19 years. Her 20-year-old son, Tommy, will be highlighted in this presentation, and he has a dual diagnosis of Down syndrome and autism. Dr. Tyson, will you start us off?
Hi, everybody. Thank you for having us today. Could I have the next slide? I just want to give you an overview of the practice, and then I'm going to turn it over to the hardworking women in our practice who have done the lion's share of the work on this topic. We have 3 offices located in western Pennsylvania. It's a suburban practice, though we have about a 20% Medicaid population. We have 33,000 patients. The practice has been in existence for a little over 60 years. We have a remarkable team, I think, that works on the care coordination. You'll hear from Brooke and Roxanne, who are our main 2 people. And then what we really want to give time to is Lori, who has just been a godsend to our practice as far as sharing her story and Tommy's story, and helping us with what needs to be done. And Lori spans 20 years with our practice with Tommy, and so she'll highlight the differences between today and when she started with organizing Tommy's care back in when he was a child and infant. The structure of the practice we have, as Renee has mentioned, the care coordination has to be with all participants, from the front staff to the clinical or nursing staff. As I say, Roxanne is our main care coordinator, and Brooke has worked with her to create care plans. What you need to do is get yourself some really good people. We were lucky to have Brooke and Roxanne in our practice, so that we could just pick. They were excited about doing this, and I will give a huge amount of credit to Roxanne, who's done a remarkable job at care coordination. Next slide, please. Some of the things that we offer in the office are evening and Saturday hours, which I think are crucial, especially on complex needs and families who have special needs children. We have an online patient portal through the website that allows people to access the information. We offer mental health services. We do not do any therapeutic intervention in the practice, but we do evaluations for autism spectrum disorder, ADHD, depression, anxiety, and we have a strong relationship with the social service community and psychiatry community in the Pittsburgh area and surrounding. We do impact testing, which many of you know is testing associated with concussions, and we try to do that oftentimes prior to any involvement in contact sports. We have a weight management program that is run by a PhD nurse practitioner who has had remarkable success on allowing some of our kids to really lose weight and get a remarkable improvement in their sense of self-esteem and their just overall happiness with the way they are. And we have prenatal appointments, which most of the pediatricians and people who are on the line know about. But basically, this is to let people know what the practice has to offer and what we share, what we can share with families prior to them having a baby. This is especially important if the family knows that they're having a baby that potentially will have special needs, because again, we can start the process even before the baby is born. Next slide. I'm going to turn it over to Brooke Pletcher, who is a remarkable nurse practitioner that we have working with us and who has done a tremendous amount of effort as far as coming up with our care coordination.
Hi, this is Brooke Pletcher. It's a real pleasure to speak with you all. So a strong need for a care coordinator became quite obvious when it was recognized that more and more time was being spent on the phone with insurance companies, writing letters of medical necessity, or just trying to find resources in the community to help with patient and family needs. The time spent addressing these complex needs was really interfering with patient care hours. So a decision to hire a care coordinator was made in 2011, and the position actually has been very lucrative to the practice as more time can be spent on billable patient care hours, and the needs are really being very well met by our care coordinator. And we're lucky enough that the providers here at Pediatrics South really do believe in care coordination, and we all work together for care coordination. Family and patient needs are assessed at each visit, and goals are identified actually at each well visit. Providers work closely with care coordinators to link families up with resources, and close follow-up occurs by the primary provider, care coordinator, or triage nurses. If a patient is unable to be scheduled with their primary provider, we work together by sending through our EHR messages to the primary provider to update him or her on the patient's status. So using EHR has been really helpful with our care coordination. It helps keep the face sheet up to date, the care plan organized and up to date. We also have an ability to place an alert and the patient's chart to notify any employee opening up that chart if the patient is on the medical home registry. And lastly, patient messages are sent to triage nurses and to the care coordinator through our clinical modules. So for example, follow-up phone calls, letters of medical necessity, or medication refills are all sent through our clinical module. And part of embracing our idea of medical home is really transitioning to a health home. We try to address all aspects of health, including medical needs, family strengths, as well as adjustment, school success, and as well as behavior needs. We've been very fortunate to establish partnerships within our community and also with our local schools. Roxanne Shoup, our care coordinator, will address this in more detail. We also identified needs for available mental health resources, just like Dr. Tyson was explaining about our mental health team. It really came about that we were struggling to find available resources for our patients and families. With that said, we developed a behavioral health team in 2010 consisting of 2 nurse practitioners and 1 RN. So behavioral evaluations and follow-up, objective survey review, as well as medication management occur right on site in our Mount Lebanon office. The behavioral health team also works closely with psychiatry and community therapists to address individual needs. Next slide, please. So that said, we've noticed huge positive attributes starting care coordination and what it's actually brought to our practice. We've definitely seen high quality care, better patient outcomes, more organized care, and ability to follow, monitor, and address needs and changes over time. Patient and family-centered care that works on building the self-advocacy skills and therefore really improving patient and family confidence. And lastly, improved family, provider, and staff satisfaction and retention. In fact, I think it really should be noted that many new families join our practice from word of mouth in the community due to our care coordination. Next slide, please.
Okay, this is Scott Tyson again. I now want to introduce Roxanne Shoup, who's our care coordinator, who, again, I cannot say enough about what Roxanne has brought to the practice.
Hi, everybody. I want to thank everybody for letting Pediatrics South participate in this call today. It's been very enjoyable working with everybody. My name is Roxanne Shoup, as Dr. Tyson said, and I've been working with Pediatrics South for about 15 years. When I was asked back in 2011 to take on this role, I knew that it was going to be a great challenge, and it has become so very close to my heart, and I love how the Pediatrics South staff has embraced the idea of the medical home. So when our patients come into the office, assessment of our patients begins right when they come in, whether it's for a well visit or maybe a possible ill visit that was maybe that has to do with some kind of stress or anxiety the family may be having. And when the patient does come in, the assessment is made at each of those visits to say, can this family benefit from care coordination? And if the practitioner or the nurse does feel that can happen, that is when they can get me involved to help them out. The goals of the families and the patient, we are here to help support the family and the patient as an individual and unit as they develop self-advocacy skills. We've seen great success with that happening. The strength-based for the practice helps families recognize their strengths to be able to be self-advocates. That seems to be a great way to help the family in having a positive outcome with whatever issues they may be dealing with. Transition within our medical home, we as Pediatrics South noticed that we needed to improve our transition policy. The practice recognized a lot of anxiety regarding transition, so ideally we start the discussion around the age of 14 or 15, hoping to build self-advocacy skills through the years so that transitioning is a more natural and expected process rather than at the age of 22 saying we can just no longer see you, find another doctor. We've decided to make it a process rather than an end. Monitoring is always continuous, as Brooke said. We do through the work list in our EHR, messaging through the EHR between staff, follow-up by the care coordinator, behavioral team, and triage nurses, along with review and follow-up of labs, x-ray, ER visits, and specialists. Brooke was right. It's become essential within our EHR that we maintain open communication between everybody in the staff to help the patients and their families. One of the biggest, most important things I think that has happened through care coordination is the linking with our community partners. We have developed wonderful networking through the medical home conferences that we attend twice a year, such as the Elks Nurses, and with behavioral health specialists that have come on board with our health team to help families to be able to see in more timely fashion rather than that 2 to 3 month waiting period that there seemed to be. The Children's Institute and home health agencies with our community have become great resources. And my philosophy has always been that there's always a resource out there to help patients and families who need it. You just have to be patient and willing to do the research. Implementing the medical home into our practice has helped our office do this, and we are seeing awesome results with our patient population. And with that, I would like to turn the slide back over to our parent partner, Lori.
Okay,
next slide, please.
Hi, everyone. Roxanne, thank you so much. And I 100% agree with what Dr. Tyson said. Roxanne has been a lifesaver for me as we are transitioning Tommy into adulthood. That is, Dr. Tyson said, I've been with the practice almost 20 years. I have 4 children. My oldest is 25, and my youngest is 6. So I will be with the practice for many more years, given my 6-year-old. Tommy is my 20-year-old, as Dr. Tyson did say. He was born with a diagnosis of Down syndrome. So at that point, I had a 2-year-old and a 5-year-old, was just trying to wrap my head around that diagnosis. Little did I know there would be many more to come. Tommy started off with, typically with the children with Down syndrome, it was the heart defects, so we were going to cardiology and, was trying to wrap my head around all the medical issues he was going to have, as well as early intervention, what was going to be best for him. So then he started into having some seizures. We had to kind of figure out what they were. He ended up having infantile spasms. So Dr. Tyson's group has helped me through so many parts of Tommy's life, so many diagnoses, both medical and his mental health diagnoses. I talked to a Dr. Tyson and another doctor at the practice at the time about some of Tommy's behaviors. 20 years ago, 18, 19 years ago, it wasn't common to have a dual diagnosis. Went to the autism center, and they did give my son a diagnosis of autism. And as hard as that was to kind of wrap my head around at the time, I know that was best for him because it opened a door to so many other things for him as far as attending an approved private school. He attends the Watson Institute here in Pittsburgh. And all along, Dr. Tyson's office has always guided me through the multiple medical issues with, I said cardiology, neurology, ENT, gastro. I could just name many, many. I would stay up at night as a parent and just write in a notebook of all the different things I had to keep straight for him. There was no one-stop shop, no one place to organize all this. So when I kind of look back at Tommy's early years and now talking to Roxanne around the care coordination, this would have been such an invaluable resource in trying to put all these puzzle pieces together to make sure I was looking holistically at Tommy as a child, at what was best for him, and not just him, but our family. At the time, I had a young, a 2-year-old and a 5-year-old, as I said. As I read through the deck, I definitely think that slide 6, honestly, is probably the most important slide in this presentation. It is really looking at all those things a parent needs to consider for their child. There's the school aspect of the IEPs, and there's the, even the busing, trying to coordinate that, and the whole medical aspect, and just family support groups. It's so much to take on. So Tommy, at this age, is in a totally different phase of his care. The medical issues are still there. They're more preventative. Roxanne has been so invaluable at helping me work through multiple appointments at Children's. Tommy has some pretty severe behaviors, a lot of anxiety. So when we put him under anesthesia, we're going to put him under wands. And Roxanne has helped me coordinate getting his teeth cleaned and dental work, x-rays. That's the only way we can really get blood work from Tommy, his yearly preventative echo and EKG, and whatever else is going on at the time. And as a parent, it would be virtually impossible for me to try to call the hospital and get everybody into that, get that all done at one time. So she has been a godsend with that. I really think another exciting thing for this is the cross-organizational relationships that were highlighted earlier in these slides. I think that's so important for parents. And to set goals. I am a very, very goal-oriented person, and I like to set goals that are measurable and want to see them. And I think this really can give a parent as well as the care coordinator a chance to do that and actually visually see it. As we go through transition age, it's been difficult. Roxanne and I have teamed very well with each other. I think I've come to her and said, here's what I learned, what do you think? And she's went and dug into information for me, and we're just kind of helping each other at this point. And, you know, I'm telling her, start the transition. If you start at 20, it's way too late. You know, it's trying to get the right waiver so he can go to the right program. It's special needs trust, guardianships, Social Security. Now they're helping me with, you know, adult day placements. What will be best for Tommy so he can still grow and be productive. I definitely am so excited about this, and I think that it's going to be helping me a lot, but I'm really excited to see it help the younger children and the parents. So maybe they can just have a little bit easier of a time than I did back then because this wasn't in place. Really, the internet wasn't much in place. So I think this just is so important. Again, Pediatrics South, I cannot say enough nice things about the practice and Roxanne and how much she has truly helped me and how I think this is just going to be huge for so many parents and really take a lot of stress off of them. So they maybe can enjoy their child, you know, and just enjoy their child in general, and just not always concentrating on this. So just happy to help out in any way I can. I think that I am passing it back to, I believe, Renee.
Yes, I am, next slide, please. Thank you, that was excellent. So this next slide here has all of our contact information. I did just want to, again, say thank you so much to Pediatrics South. They really are a really strong practice with multiple sites, as you heard, and they remain independent, and they really exemplify the medical home and care coordination model. So I can't thank all of you enough. You really are the dream team. And what we've included there are all of our email addresses as well as Pediatrics South website, which is really wonderful, and their office number. And as I said, all of us are willing to be resources and contacted after this webinar. Next slide, please. We also have put together some resources. We have a link there through the slides that all of you have access to for the AAP policy statement, as well as a resource guide, Building Your Medical Home, the Care Coordination resource guide. There's also a how-to video series, which is really wonderful, that talks about, especially if you're a visual learner, the partnership and teamwork in the medical home. Also, the National Center for Medical Home Implementation, American Academy of Pediatrics, the National AAP, has additional care coordination resources on their website that you can get directly linked to there. Next slide, please. And just a few more resources just to highlight. The care coordination curriculum that I had mentioned in my slide, this is Renee again, that you'll also hear about in a future webinar. Dr. Antonelli and Hannah Rosenberg will be talking more about that, but in case you wanted to preview, you can link to that there. The care coordination measurement tool, which allows you to sort of assess, take the temperature of care coordination and inform some next steps with quality improvement if you're interested. There's a link there. The ARC, care coordination measures for primary care practice. ARC is the Agency for Healthcare Research and Quality. They have a nice atlas there that you can take a look at if you're interested. It's very comprehensive, and also highlighting, I think we've mentioned Rich and Hannah several times in our webinar, there's Hannah's email, and you'll be hearing more from them in future webinars. And so I think we'll be turning it back to Linda, and I just want to thank all of you for participating today.
My goodness, this has been really an amazing experience to join you electronically. We have many questions, and what I would have to tell you is we have too many questions for the amount of time. This webinar ends in 1 minute. What I also want to tell you is that the next 2 webinars are going to answer many of your questions, so please join us again. The other mechanism we have is that you will receive some of the answers in individual emails from the AAP staff. Oh, no, I just got a message saying we do have more time. Well, isn't that wonderful news? Okay, well, in that case, I think I have 10 questions here, and I am going to start with one to Renee, and that is, Renee, could you please discuss the difference, briefly, between case management and care coordination?
Sure. And we actually, in the policy statement, do go into this in a little bit further detail. And I think that I will just say, suffice it to say, as sort of a disclaimer, that sometimes folks will use those terms interchangeably. So, in fact, you know, when we sort of think about, for those of us that kind of think about care coordination, you know, some folks may use that term and in fact call it case management. But suffice it to say that often when folks refer to case management, they refer to sometimes things that occur from the insurance perspective, so that you are looking at utilization review, individual clients, often, you know, some insurance companies will actually have case managers that actually are employed and work directly with clients. Sometimes hospital systems have case managers that are looking at, you know, and at times those case managers will actually, you know, try to link certainly their clients to services. When we are talking about care coordinators, we are thinking about folks like Roxanne that might sit in the practice setting or in the community, and will also, you know, again, work outside of just the medical arena and not just work specifically with utilization review. And as we mentioned earlier, kind of thinking about linking to community resources, working in the educational sector, and really at times care coordinators are community-based. They're not always in the practice setting. So you know, we just like to distinguish between the two, and really kind of thinking about when we talk about care coordinators, kind of operationalizing those definitions that that we mentioned earlier. But you will hear folks use the terms interchangeably.
Excellent. Could you also, Renee, talk about integrating care plans into the electronic health record? I believe it was mentioned that a protected shared website or patient portal would be ideal. Could you talk just a bit about how that works rather than the cut and paste or the templated document?
Sure. And I think ideally, if you can set up in an electronic health record, you know, some electronic health records have this built in already, but the idea would be as you go through your visit as a healthcare you know, professional, whether you're, you know, physician, nurse practitioner, physician assistant, nurse, that you're going through that healthcare, you know, visit template, and you're doing your visit as you normally would, and then there's sort of this separate document that would be pre-populated by the things that you're entering. So, for example, you're reconciling medications, or you're putting in the child or youth's diagnoses, and you're putting in plans. And then, you know, the IT folks are far smarter than I, but you sort of have this behind-the-scenes template that sort of sucks out the information. It's pre-populated, again, coming right from your visit. And then you sort of, you know, in many health records, it's sort of a different template that you might go into. You may have to add a couple of things here or there, but the ideal is that with an electronic health record, you're not having to retype things. You're sort of, you know, already using a lot of, you've already set up the template so that some of what's already in your visit is pre-populated. You may be going in and adding things like goals, or maybe adjusting things like medical equipment, but that, you know, by and large, from an efficiency standpoint, a large part of that care plan is already pre-populated. It doesn't all have to be pre-populated by the physician, just like many times in our visits we have other folks, you know, vital signs or anthropometric data is filled in. And then that care plan is there so that folks who are maybe it's specialists, or if other folks have access to your medical record, they can see that care plan. plan that ensued from that visit. And let's say a family or patient calls in, that care plan could be updated in real time so that an accurate, maintained care plan is always part of that child's electronic health record that's in there as, a document. And then for those of us that are using the patient portal, which is part of meaningful use, if you are engaging in meaningful use, but the idea of a patient portal is that, and many of us, I think, who are accessing our own even adult physicians are recognizing that as a patient, you would go onto a website. You'd have, it's HIPAA and password protected, so that you would go on, and many patient portals allow you to request referrals or request appointments or ask a question. For some practices, families can view an immunization record. So parts of the health record are visible to patients and families outside of that medical visit from home. You basically just need an internet connection. And the idea of that care plan would be, in my opinion, ideal, that care plan becomes one of those documents, just like the immunization record or last health care assessment, that family can then go on and ideally can be at the school setting, a specialist visit, in the community. They could access that care plan, and that care plan, as it's updated and maintained, is pushed out to the portal, and so that the family constantly has access to the most updated, accurate care plan. And that allows, folks to be able to see that independent of whatever electronic health system or health record you're using, and you could use that across systems. And so that would be the ideal, and that again, that family could print it out if needed, but at least it could be viewed in an emergency setting or whatever ensued.
And before I move to the Dream Team with questions, Renee, one more. Do you know of any apps that would be able to be sent out to some of our listeners that would give them a head start in this work? Are there apps?
Yeah, that's a great question, and we've actually even talked about that. I have heard of different different things that families have used. Some folks have even used flash drives, and this idea of even using like Google. I mean, I have not found an app. We have. One of the things that I think is a big concern with a lot of the apps is like the HIPAA, the information protection with it. So I have not, and there may be folks that are aware of this, and I just haven't come across one that has sort of been kind of vetted and endorsed as sort of like this is, stamped. And again, as I say, there may be one out there that I'm not aware of. One thing I will say is that what folks may want to look into, and I've been working with some folks in our own health system, electronic health record, that the patient, so what I'm aware of that is, at least what I'm looking into utilizing, is that the electronic health record companies, so whether it's Epic or NextGen or Office Practicum, whatever health record you're using, many of those folks are developing apps that then the patient can load that app on their phone so that you can access that portal and access that via an app and get into, and so that it has sort of all of the certifications and HIPAA kind of compliance available. And that's kind of what we're pursuing in my own health system. So again, I would encourage folks to kind of talk to or think about the app as opposed, so you don't have to go onto like Safari on your phone and access the portal, which sometimes it doesn't support. Many of the electronic health records are looking at apps to do that, and some of them have it already. But again, I'm not aware of an independent app.
This is the next big thing that we can all be looking towards and participating in. Some questions for the Pediatrics South team. People are very interested in how you make this work. And I'm going to give you several questions at once, and then Scott, you and your colleagues can answer. Do the pediatricians rotate to the clinic sites? What % of the practice are children with special health care needs and youth with health care needs? Do you bill for the care coordination services? I'll start with those three.
Okay, this is Scott Tyson. I'm going to just kind of, we'll all sort of chime in on those. Number one, at present we don't get paid for those, but as Brooke said, it's really freed up a lot of time to do other patient care, which is billable hours. So we've really found that with ROCS doing a lot of the care coordination, it has paid for itself. And again, ultimately, it comes down to managing the family and their children so that they get the care that they need and the support that they need and the help they need.
We try really hard to keep the same providers at each site. Occasionally, we will go to a different site that is not our home base, to cover for illness or cover for vacations, but we do try to keep it consistent so that we get to know, just because it is such a large independent practice with over 30,000 patients, it's nice for that patient care continuity.
And what % of the practice would be identifiable as having special needs?
You know, that's a great question. I would say probably 10%, but at least 10%. The issue is that what we're trying to do first is get our special needs kids really taken care of and addressed, and families addressed. When you really sit down and look at it, there's a huge population that may have 1 or 2 needs that can be addressed. But what we're really working on aggressively at the start is getting those complex patients. And Rox and Brooke oftentimes will sit down when they have free time, which is not very much. But they'll sit down and they'll really look at a patient that we need to get into the care coordination plan and review the chart, look at what special needs that family has. And Rox will then work closely with the family on that. So I'd say 10%, but that's a guess. But again, those are probably the ones with the most complex needs.
So related to that, I think, is what ratio of staff to families you have, and perhaps that's not a number easily retrieved. A related question is the kind of qualitative, quantitative data that you are collecting about the overall work of your team.
Yeah, that's a great question, and I think that we're just starting to do that now. We've been on EHRs from a scheduling standpoint since 1993, but we're constantly upgrading our EHR so that we can quantitate that data and gather that data and see where it is able to help the families navigate the system. So we're really, you know, we're really flattered by being called the Dream Team. But what we're constantly doing is you know, working with people like Renee to maximize our success on the plans that we set up with the families. We have about 80 employees. So for 30,000 patients, we have 80 employees. We have 16 professionals, 9 full-time equivalents. And so what I think Brooke's point was very well taken is that at many of the sites, the practitioners know the patients very well, the special needs patients very well, because they're seen frequently. And so that, I think, has allowed us to maximize our success with not as large, possibly, a staff as others might have.
We're getting close to the end of our readjusted time here, and we truly have covered the questions. One last question is, how do you market or promote your care coordination services to the practice?
We do it on the website, and like Rox said, we do it. A lot of it is by parent referrals. As we get parents. Just this morning, for example, I had a family who came in whose child has alopecia, which is not an overly complex issue, but clearly there's a lot of issues associated with school and friends and families wondering about his alopecia. And this mother just volunteered that if other families had issues associated with alopecia, she belongs to 2 alopecia groups. She wanted to let us know that she would be a parent, you know, work with us as a parent partner to help with those families. And so we immediately introduced her to Roxanne, and so Roxanne now has her information if there's any issues. I want to reinforce, we are all available by email, and you could reach us on our telephone number, the main number that we left. We're happy to answer questions that people have offline by email, so don't hesitate. This is the beginning of a process that we're going through right now with our practice as well as many practices. Don't hesitate to email any of us. We're happy to answer questions that you have.
Thank you. This webinar is about to to end, the recordings, slides, and questions will be archived in about 1 week on the National Center's website. You will receive a questionnaire very shortly, and it's in an email. Please do complete it. If you have anyone sitting at your side listening to this, in addition to yourself, please indicate that on the form so that we know as close as possible the exact number of people on this call. The National Center for Medical Home Implementation houses a number of care coordination resources on their website. Please visit the links. You've seen them already in this presentation. This is the first installment of 3. Do not miss the upcoming 2 installments. The second one will be April 22nd, and it will be Pediatric Care Coordination, Beyond Policy, Practice, and Implementation. That was today. I'm sorry. The next one, Beyond Practice, Fostering Diverse Partnerships for Effective Care Coordination. That is the one on April 22nd, and you can register and find more information at the website. Thank you for caring about this topic and for all the work you do, and we look forward to you joining us next time. This ends this presentation. Thank you so much. Bye-bye.